And we're back with Marc Surdyka. Welcome back, Marc. How are you doing?
I'm doing well, Chris. Thanks for having me back.
Of course. We didn't really touch on it in our last conversation a few weeks ago by the time this comes out. Our previous episode on low back pain, a practical guide. We're going to start making more of these frequent kind of practical guide conversations and episodes to be a little bit more patient or clinician friendly. And it's just going to be me and Marc having a back and forth about a specific topic as opposed to bringing on a researcher. And they're going to be kind of correlated with the timing of these resource guides that we're going to be putting out on the monthly newsletter. So as of our recording right now, it's August 1st, and the acute low back pain newsletter just came out. We had a podcast conversation about low back pain. So on a monthly basis, we're going to start having these podcasts as practical guides that will be a nice kind of parallel to the resource guide topic. So this upcoming month that this will come out in September, it's going to be all things plantar fasciitis. So that's what we're talking about today. We're going to start really basic with just kind of identifying and defining what actually is the plantar fascia. And then we'll go all things management, diagnosis, et cetera, of plantar fasciitis. So Marc, can you just start out with what actually is the plantar fascia and why do we have it?
Yeah, so the plantar fascia is a dense, fibrous connective tissue that's pretty expansive and intricately connected to many muscles and structures on the sole of the foot. It's called the plantar fascia, but due to its composition and function, it actually shares many similarities with ligaments and tendons. For example, it's often described as providing support and stability to the medial longitudinal arch of the foot while standing, but it also does this and aids with energy storage and release during walking via the windlass mechanism, which was first described by John Hicks in the 1950s. And a windlass is like a winch on a boat to pull up an anchor or heavy load. So that's what he named it after. But essentially, and don't do this if you're driving, but if you're sitting, your feet are flat on the ground, you're barefoot, you can reach down, grab your big toe, and lift it up into dorsiflexion or extension, whichever you prefer. Lift it up, and you should see the medial longitudinal arch of your foot rise. In addition with that, you should feel some tension increase in your plantar fascia. So that's a demonstration of the windlass mechanism. Now, this occurs during the gait cycle, and it applies to this kind of energy storage and release that I talked about. So a portion of the gait cycle is known as loading response. And during loading response, you can think of your foot kind of unlocking. And it unlocks because you want your foot to be adaptable to the surfaces that you're walking on, whether that's flat ground, sand, rocks, etc. So it's adaptable, and it also helps with shock absorption. Then as you move through the gait cycle and you move toward terminal stance, which is when your foot is kind of positioned behind you, and then you start to lift your heel up off the ground and you kind of roll over and push off that big toe, that's more of that terminal stance. So you go from this more unlocked foot during this loading response, and that's where you get some of this energy storage of the plantar fascia. And then you go towards the terminal stance and you get some of this energy release. And actually, I didn't describe during this terminal stance, this is where you get that windlass mechanism, and that helps create a more rigid foot because you want your foot to be more rigid during terminal stance. So that's kind of an example of the windlass mechanism, this energy and storage and release mechanism. And obviously it's not as the same extent of energy storage and release as, let's say, the Achilles tendon. But there also is this nature of the plantar fascia kind of distributing mechanical forces. And this is going to be relevant to maybe some of the exercises and what we describe as it relates to activity modifications and load management. But anytime the Achilles, the calf and Achilles complex is loaded, you're going to get load and strain on that plantar fascia. So same thing with walking, with running, with doing a heel raise, you're contracting that calf Achilles complex. Well, you're also going to be transmitting those forces from that calf Achilles complex to and through the plantar fascia. And this is actually also influenced by the position of the big toe. So the more, once again, extended or dorsiflexed that big toe is, as you're loading your calf Achilles complex, the more strain that's going to go through that plantar fascia. And we'll talk about why, that's why in some research papers, they've looked at placing like a towel under your big toe to preposition it into that more extended dorsiflex position so that you're getting more load through the plantar fascia. All that to say is the plantar fascia is really loaded in two scenarios. One, any kind of weight bearing and standing, right? Double leg standing, single leg standing. And then anything really that loads your calf Achilles complex because of that transmission of force, from that into the plantar fascia. So walking, running, jumping, heel raises. So that's all I got. I try not to make this too complicated. I feel like some people probably like that. A lot of podcasts are 2 to 3 hours long because of all the detail. So if you want me to be more in depth regarding anatomy and function in future episodes, let us know. And then you can also check out the blogs I've written about plantar fasciitis because you can read the references I took a lot of this information from. And so let me know, Chris, if I should clarify anything there.
Let's go into actually what is plantar fasciitis and how is it diagnosed. Correct me if I'm wrong, Mark, but I would assume and plantar fasciitis is considered a diagnosis of exclusion.
Yeah, my thought process for most diagnoses and patients or clients that I'm seeing is that I actually, and this could be an incorrect way of thinking about things, but I try to think about everything as a diagnosis of exclusion just to try to prove myself wrong. So if I think, oh, it's probably this, that's great. Can I prove that it's not all of these other things? And I think that was kind of a mentality that was driven into me in residency. Obviously, the subjective exam, objective exam, they flow, but as a new grad, as a resident, you're learning how to create that flow. And so what we would do is we do the subjective exam, step out of the room, and I'd have to list all of my possible differential diagnoses. And based on all those possible differential diagnoses, 5, 10, whatever it may be, we go back into the room, perform an objective exam, step out again, and then reorder my differential diagnoses. So I do think that's a fair way to think about it, especially when we're talking about a lot of the things that we're looking at that are musculoskeletal in nature. There's less at stake. What I mean by that is that, if somebody misses cancer or infection or something like that, there's more at stake there. So our responsibility as physical therapists is to make sure that we're not missing any, or that the person in front of us doesn't have anything that, is going to up those stakes. So trying to exclude those diagnoses. And we can talk about what that means and what that looks like.
So typically the individual presenting with plantar fasciitis is going to have pain on the bottom of the foot, and it can be more localized to the heel. And we'll get into kind of the more updated term of plantar heel pain down the road, but the symptoms on the bottom of the foot can also be into the arch, into extending the more proximal aspect of the plantar fascia, but there will be symptoms in that plantar aspect of the foot. There's also a lot of other things that could be presenting with symptoms in and around that area. So these are the things that we would be wanting to hopefully exclude or figure out, is this the correct diagnosis? If someone is coming in with the diagnosis of plantar fasciitis or they're not, what else should we be asking? And the general theme is, this is typically an insidious onset. These symptoms are occurring gradually. So if we're hearing that someone's having this acute, specific onset of symptoms, it was a traumatic episode, that would be unlikely to be the diagnosis solely of plantar fasciitis. But general things to kind of think about in and around that area of the heel and the bottom of the foot: is this more of an Achilles related pathology, an Achilles rupture, an Achilles tendinopathy? Is it the calcaneus, the bottom of your heel, a calcaneal fracture, a stress fracture? Is it an actual plantar fascia rupture from an acute mechanism? Is it something more in the metatarsals, the navicular, the other bones of the foot, from a stress fracture or a fracture perspective? If someone's having symptoms that are radiating down the leg and they're having more of these radicular pain or radiculopathy based symptoms that are coming more from the lumbar spine, there's the concern around neuropathy, or individuals that have diabetes and are having sensations or changes or lack of sensation around the foot. All of these things could be initially considered as or diagnosed as plantar fasciitis, but is that truly the case? So those are some of the things that I would be thinking about or asking or differentiating through a clinical exam. Do you have any others that you would consider, or anything you want to add to that, Marc?
Yeah, so I think the history and presentation, as you mentioned, are really important. Plantar fasciitis is typically going to present as more unilateral in nature. So if someone is experiencing bilateral symptoms, that should lead you to other questioning about something that's more systemic or nerve related. As you suggested, same thing with the history and presentation. Are they experiencing numbness, tingling, right? You're going to be maybe thinking about the tarsal tunnel and some of the nerves in that area, stress fractures, et cetera. And then the location of symptoms is really important. Typically, you would expect it to be very localized to that calcaneal tuberosity on the bottom of the foot. So if somebody is pointing to the back of their heel, you shouldn't expect it to be plantar fasciitis. So it's going to be on the bottom of the foot at that calcaneal tuberosity, and you're going to expect it to be on the medial aspect of that. So the medial calcaneal tuberosity. So it's going to be off the center towards the midline. And if you were to, put your thumb there and press into it, there should be localized pain. As you said, there can be, there's some research of people describing more diffuse and spreading of those symptoms. I think, especially as it becomes more chronic in nature. And then also, and that's more of the physical exam. And then I guess also in terms of the history and presentation, that first step out of bed in the morning is a classic sign of plantar fasciitis. So you've been lying in bed all night, you were sleeping, you're lying in bed all night, you swing your legs over the bed, you put weight on your feet, you start to walk, and that's extremely painful. And then maybe it starts to diminish a bit with some activity. And then, prolonged standing, prolonged walking, all of those things can contribute to a worsening of symptoms.
And that, I think, is a good lead into who often or who typically has or gets plantar fasciitis. It's these two kind of ends of the spectrum: individuals that are highly active, that are participating in a sport or an activity that requires a lot of demand on the lower leg and the foot and the plantar fascia. Typically runners can have these onset of symptoms, and also individuals that are just spending a lot of time for their job demands or their occupation on their feet, either just standing in one place or walking around. And then you kind of have this other side of the spectrum where these individuals are largely sedentary. They may be middle-aged to a little bit older. They aren't doing a ton of physical activity potentially, but they could have these symptoms as well. So it's these two kind of separate ends of the spectrum of really highly active individuals for the nature of their sport or activity interests or their occupation or both. And then these other individuals that may have multiple comorbidities or overweight, and the middle-aged to older population are also at a higher chance of having plantar fasciitis. Anything you would add to who generally gets this diagnosis?
Yeah, and the way that I think about that, and obviously I'm going to simplify this, but as we talked about in the tendon episode, systemic factors always have to be a consideration as it relates to musculoskeletal pain. So this is an oversimplification, but for the runners, I think about them having a very high capacity to tolerate load. However, maybe as it relates to their goals, they're training for a half marathon or a marathon, they exceed their already high capacity by introducing more load than what they can tolerate. And therefore, that presents as plantar fasciitis. And once again, there could be other factors that are contributing to that. And then for that other side of the spectrum that you described, maybe the more sedentary individuals, I think about, well, perhaps their capacity is actually severely diminished. So even a little bit of load, a little bit of activity exceeds that capacity, maybe their prior capacity, because of continued, diminished function and activity and whatnot.
The question around, is imaging necessary for the diagnosis of plantar fasciitis? My understanding is no. Imaging would potentially be indicated if there's concerns around other more sinister pathology, like a stress fracture or an actual fracture, or something that would change the management of someone's case. My understanding as well is that it's assumed that there may be changes to the plantar fascia, but the severity or the extent of the changes may not change the management and is not necessary for an appropriate kind of diagnosis of plantar fasciitis. Anything you would add from the imaging standpoint, Mark?
Yeah, I think the big concern for patients previously, and this is probably reported less often now as a concern, is a heel spur noted on x-rays, because the research has demonstrated that there's not really an association between plantar fasciitis and heel spurs and the prognosis of plantar fasciitis and heel spurs. So as we say with many other body regions and diagnoses, it's most likely in most cases an incidental finding. So like you said, perhaps you get an x-ray to rule out a fracture if there was a mechanism of injury to suggest that's a possibility. Or maybe you get an MRI to rule out a stress fracture because the mechanism of injury, once again, suggests that might be a possibility. Otherwise, if the clinical diagnosis, history, presentation matches that of plantar fasciitis, it is a clinical diagnosis that doesn't require imaging.
Now, we've been using the term plantar fasciitis, but the term that's also been utilized more recently is plantar heel pain or plantar fasciopathy. For a long time, plantar fasciitis was used as kind of the main term because there was this understanding or assumption that the plantar fascia was inflamed and that the inflammation of the fascia was the biggest driver of symptoms, and that inherently guided the management of plantar fasciitis. The inflammatory-based response would inherently mean treatment with NSAIDs and rest and ice. And as the research has progressed over the past few years and decades, there's been an understanding that, yes, there may be an inflammatory component, but there's a lot of other factors that are also influencing the symptoms and the onset and the duration of plantar fascia pain. And so there's this more umbrella, more broad terminology of plantar heel pain, or sometimes plantar fasciopathy. And this is what Mark dived into, and we've had other guests talk about in the tendinopathy conversation between tendinitis and tendinopathy. Not just a purely inflammatory response. Yes, there can be some inflammation contributing to symptoms for some individuals, but that doesn't necessarily mean that it's the only contributor, it's the primary one. And this understanding of changing the terminology to something like plantar heel pain or plantar fasciopathy also indicates that there's kind of a change in treatment thought process and general recommendations. I'll stop there. Do you have anything to add to that, Mark?
Yeah, I would say Henrik Reel, who we've had on the podcast, published I think it was a one-page editorial in 2017 pushing for the term plantar heel pain for the reason that you stated. And it's not to say that, yeah, there is never any inflammatory markers present. It's just that at this time, inflammation doesn't seem to be the primary driver of symptoms. So that suffix itis in this context doesn't make that much sense. Now, we don't necessarily have perfect consensus on what to call it, because some people might push back on the general label of plantar heel pain to say, well, a lot of things could be plantar heel pain, not just as it relates to the plantar fascia. So I think as long as whatever you want to call it between colleagues or to patients and clients, the most important thing is that follow-up of description. So if you decide to call it plantar fasciitis, it's just important to say, well, maybe this complete rest NSAIDs ice isn't the primary management strategy for these specific reasons.
Yeah, I could, and I use the term plantar fasciitis with my patients because it's what everyone is aware of, or the vast majority of patients. And I don't think it's absolutely necessary to educate them on, actually, no, you should be using the term plantar heel pain. Let's go into associated risk factors and kind of the messiness of, prior to this recording, what we were talking about. So there's a variety of potential factors that people may have associated with either the onset or the duration of their symptoms. And I think maybe some are a little bit more clean cut than others. So some that are commonly talked about in the literature are individuals that have higher body mass index. And there's caveats of, they'll say higher BMI in non-athletic individuals are at potentially a higher risk of having plantar fasciitis. Running, or people that are runners, work-related weight-bearing activities, like we discussed earlier, just the occupational demands of lots of standing or walking. And then this one's a little bit more controversial, the limited dorsiflexion, or the limited range of motion of the foot's ability to kind of bend towards someone's body or towards their face. So some of these, there's, I think, a little bit more concrete understanding as to maybe why they're influenced in increasing maybe the odds of someone having plantar fasciitis. Maybe we can dive into a few of them, Mark, and kind of give our perspectives. The higher body mass index, maybe we start there, and you kind of discussed it earlier, but the potential reasons why someone may be at a higher chance of having plantar fasciitis if they have a higher BMI, like you alluded to earlier, these kind of systemic changes that may occur to the plantar fascia and to the other tissues that ultimately may lower someone's overall kind of tolerance or capacity for activities that load and involve the plantar fascia when integrating to walking or to daily activities, that systemically their ability to tolerate even low-level daily activities is now decreased because of the kind of metabolic and systemic changes that may occur alongside having a higher body mass index. Do you have anything to add to higher BMI potentially posing kind of a quote unquote risk factor?
Yeah, as we briefly touched on off air beforehand, is that I typically describe these things as associations as opposed to risk factors, because there's not really strong prospective research as it relates to this information. So to me, it's important information to know, and it's something that I can discuss with a patient or a client. But for me, yes, I normally say association as opposed to risk factor, because it's a chicken or egg scenario in most of these cases, right? Is it, do they have plantar fasciitis because of their higher BMI, or do they have higher BMI because they have plantar fasciitis and therefore they have reduced activity levels.
Yeah. And then for the association with someone like a runner, is it because of the volumes or the intensities or the total dosage, like you said earlier, potentially exceeding someone who already may have a high capacity? It's just currently exceeding what their tissues can tolerate. Or an individual who may be new to running, where it's a kind of the same thing, but it's a much quicker, kind of too much too soon response for someone that hasn't done much of the activity and is now going into it at a rate that may be exceeding the tolerance of, or the capacity of, their plantar fascia. The work related weight bearing activities, I would say similar concept to something like running, just the demands and the total kind of duration or volumes of the loads on the feet and the plantar fascia throughout the course of the day, throughout the course of the week and the month, is kind of cumulatively too much for the plantar fascia, and it's giving those signals, and the symptoms will come on. I'm curious to hear your thoughts, Mark, but I found the more challenging populations that have this diagnosis are the individuals that have these job demands that are hard to modify compared to maybe a more athletic population that is having these symptoms onset and provoked with something like running. But the job demands where they may be forced to be in these certain standing positions, or this amount of walking throughout the day, trying to minimize that or to adjust it just is harder to do. I don't know if you've experienced that, but those type of individuals coming in, I think it's a trickier management strategy compared to some of these runners or other athletic active populations.
Yeah, if you think about someone who works in construction or in the military and they're on their feet all day, they might not have the ability to take breaks as much, or not as much flexibility in their schedule. They might not have flexibility in the footwear they can wear at work. So I agree that that can be challenging because perhaps there's less modifications that can be made on a day-to-day basis. And as you know, and many of the listeners know, I lived in Los Angeles for a long time and would work with individuals who are in the film industry, and not necessarily just actors and actresses, but like grips and people who work on set that are just standing and moving things around and lifting things. And so same thing, they're on their feet. And sometimes if they have a long filming day, 10 hours, 12 hours, 14 hours, my recommendation of, hey, get off your feet, go sit down, enjoy some of that cheese board they have sitting out, like that might not be an option for them because their work requires them to be on their feet and moving. So I agree with your statement there.
Going into the prognosis of how long does this generally take, and what a lot of patients will ask is, when will these symptoms improve? There is variation, like all diagnoses, but there's a general understanding with plantar fasciitis or plantar heel pain that there's a gradual onset, and more often than not, there's a gradual resolution of symptoms that can take multiple months, up to a year, up to multiple years for some. And similar to that kind of conversation around tendinopathy, that these changes occur slowly, and there can be some kind of ebbs and flows throughout that recovery timeline, but it's considered to be at least a multi-month condition for most, and it's not uncommon for symptoms to last 12 plus months. So setting that expectation to individuals that we don't have a magic solution to alleviate all symptoms and resolve everything within a few days or a few weeks, that this is likely going to take longer, and that we're looking for changes over weeks and months, and signs that we're moving in the right direction, or that your tolerance to a variety of activities or loads or durations is improving, but that I wouldn't expect drastic changes extremely quickly. Do you have anything to add there, Mark?
I think something that comes with clinical practice too is having that specific conversation of a patient asking you, how long is this going to last? And oftentimes there's going to be uncertainty there, and you might have to say, I don't know. But if there is research associated with a given diagnosis, you still have to apply that information to the person in front of you. And what I mean by that is that if the natural history of a study says 1 year and it was based on patients who have had symptoms for 3 months, but the person in front of you has had plantar fasciitis for the past 10 years, then you might have to tailor your education a bit. And if someone says, I've had plantar fasciitis for 10 years, how long is this treatment going to last? You might have to say, I can't give you a definitive answer, but given the fact that you've had it for 10 years, we're probably going to expect this to take a significant amount of time. But what we can do along the way is make sure that we're at least trending in the right direction. For someone in your situation, I might expect at least 3 months of care to make at least a dent in your symptom, or whatever it is, right? I'm just giving an arbitrary example. I don't have a specific patient in mind, but understanding that you do have to tailor these conversations to the people in front of you, even as we just talked about, based on someone's occupation. If someone's a runner and they say, oh yeah, I can easily swap out my running for biking and my plantar fascia feels great doing that, then you might expect them to have a better prognosis sooner than that construction worker who has to work 60 hours a week wearing, these hard boots, and they're having difficulties making other modifications, right? You might say, okay, well, this is going to be a little bit trickier because you're not able to influence what you're doing on a day-to-day basis. So I agree with everything that you said, Chris, and I'm just adding some nuance to that for both clinicians and patients.
The key points to discuss with patients, there's a variety of things that I think is worth diving into. And for individuals that want to look at these and further information on this topic, again, the resource guide that comes in the E3 newsletter at the beginning of September will provide this information. But we kind of listed out 4 kind of big things to discuss and to have a conversation around plantar fasciitis or plantar heel pain. So the first thing is kind of encouraging an individual to find a tolerable level and a type of physical activity and exercise, kind of reassuring individuals that completely avoiding pain is not necessary. And there can be contexts or situations or certain types of activities where it is appropriate to temporarily have a full removal or modification of these more aggravating activities in certain contexts. Like Mark, you alluded to with running, if it's too provocative, even with some modifications in the intensities and the volumes and the frequencies, and it's obvious that that is kind of the main provoker of symptoms, it may be worth modifying the aerobic exercise into something like a stationary bike temporarily. And in other contexts, it may be just shifting the amount or the load or the total duration of an activity or series of activities, and not fully removing it. But I think there's obviously very different contexts as to what is provoking individual symptoms. But I think that the main takeaway is that we want someone to be still as active as possible, and when appropriate or when necessary, to modify or to fully remove temporarily certain activities. The reassurance that because the diagnosis of plantar fasciitis or plantar heel pain it's not a stress fracture, it's not an acute injury, it's not something that we need to fully remove load into the system. We want someone to stay as physically fit and healthy as possible and provide the appropriate kind of range or bandwidth of loading into their body and into the foot and to the fascia as someone can tolerate. Do you have anything to add to that kind of initial mark or point, Mark?
With regard to encouraging physical activity, I have a few thoughts. One is that sometimes it can be fine to be very generic and just give that statement to a patient, and they'll learn how to adapt that education to their individual life and their specific needs. For others, you might have to get a little bit more detailed and a little bit more in the nitty gritty. And I'll compare it to dieting. And like, I'm not trying to blame someone who is trying to lose weight but hasn't lost weight. But let's say someone is trying to lose weight and they haven't been able to, and they report that they've been eating really healthy. And so they're unsure why they haven't lost weight. But maybe they don't realize how much oil they're using or how much butter they're using and the amount of calories in that, or they don't realize the amount of calories in the dressing that they're using for their salad, or they don't realize the calories in their peanut butter, or whatever it may be. So while they're mostly doing the right things, maybe there's just more specific tracking of those different calories that could be helpful for them in their pursuit of weight loss. And the same thing with somebody with plantar fasciitis or any lower limb injury is that actually looking and tracking your steps can be very helpful on a day-to-day and week-to-week basis. So you can find your baseline of tolerable physical activity and then decide when it's appropriate to try to gradually increase that on a day-to-day and week-to-week basis. And then that's an objective marker of progress, but that can also be used as an intervention to say, hey, I went to Disneyland and I walked 20,000 steps. I've been normally walking 5,000 steps. Okay, it makes sense that my plantar fasciitis is extremely flared up, and it's been flared up for the past 3 days, as opposed to saying, oh, my heel really hurts and I don't know why. You have that data. And then the other thing I wanted to touch on is that sometimes you might have to handcuff individuals a bit, or ball and chain them a bit for the runner who just cannot pull back. You try to give that recommendation of, hey, you can run based on your tolerance, and you just make some modifications as needed. And maybe even sitting down and doing that isn't enough. And maybe you need to say, okay, we're going to take a break from this for a certain period of time. We'll cross train with cycling or something else, and then we'll reintroduce it. Now, obviously, the goal is always to try to disturb someone's life as little as possible, make as few changes as possible. But there are some cases where that might be necessary, just because someone can't limit themselves, perhaps, from continuing just to push into the pain that's prolonging their symptoms, perhaps.
One of the second points we added to discuss, and what we've touched on earlier, is just highlighting this updated understanding of plantar fasciitis and how inflammation may be one component, but it's not the single primary sole driver. And reiterating that what was once used to be thought of as a rest, ice, NSAIDs is no longer a series of primary treatment strategies. And what the more beneficial or recommended or updated strategies are from a management standpoint. So switching that gear of, we need to fully kind of take this as an inflammation-based diagnosis, just kind of switching that understanding and communication with the individual. Number 3, we'll go straight into it, just like we talked about earlier, but having that conversation with the individual and tailoring it towards them of, how long they've had this already can change how you frame it, but reiterating that this is a commonly occurring lengthy recovery over multiple months and sometimes multiple years, and that we wouldn't expect really quick changes for someone. And to that example you used, Mark, of someone who's had symptoms for 5-10 years, that is not going to resolve in a week or 2 or even a month or maybe even 2 months. But if you're seeing slow changes over time within these first few months and things are moving in the right direction, that's a more realistic expectation and something to set that framework for starting that plan of care. The fourth one, and this is the treatment standpoint or the management option standpoint, is providing kind of a host of self-management strategies for individuals, knowing that these symptoms can linger for quite a long time, providing resources and options and ways to experiment with the patient on what are some things we can see in the short term that can help you just get through your workday or get through the demands of what you have to do, and what are some other things we can do to kind of hopefully move the needle forward and improve these symptoms and return your function over time. So there's a variety of things that can be recommended or can be explored. I'll list kind of a variety of them, and Mark, if you want to add anything to them, you can. One is selecting the most comfortable footwear options. Like you said, Mark, there may be contexts with certain occupations or certain jobs where you may not be able to adjust what you're wearing. But for individuals that have the ability to explore a variety of different types of shoes that may feel more tolerable on the bottom of their feet during daily activities or the demands of their job, or within there, utilizing some type of over the counter or custom orthotic can just change kind of the positioning and the inherent loads going into portions at the bottom of the foot that may provide kind of an increased tolerance to more standing or more walking for those individuals. That's one option or strategy to consider. Before I go into the others, do you have any thoughts with the footwear or the orthotic standpoint, Mark?
I'll talk big picture after
Cool.
you continue.
Great. Second, managing the load of the activity by breaking up prolonged periods of standing or walking. So if someone is just doing a ton of prolonged activity that is provoking their symptoms, can they break it up through parts of the day or throughout that session or throughout the job by just changing the position, by sitting down, or by limiting the total duration in one bout of load going into the bottom of the foot. This is similar, but from a running standpoint, modifying the running volume or the intensity. So if someone's symptoms are aggravated with running, what are the things we can change? And Mark, to your context or to your example, there may be times where we're fully removing running for a period of time, may be the most appropriate option. And then experimenting with stretching, taping, and exercise-based variations or interventions. Stretching can provide some temporary short-term symptom relief and allow people to get through the demands of what they have to do for their day-to-day. Taping and stretching both are considered these short-term symptom relief or symptom kind of dampening modifiers. They're not changing the plantar fascia. They're not changing the structure. And I think some of that education is important to bring about or to mention that these are ways to help modify the intensity of your symptoms. Your plantar fascia is super rigid, super taut, super strong structure. We're not changing any of your fascia itself, but these are ways that we could help your symptoms become a little bit more manageable. And then an exercise-based intervention, there's a variety of options here, but more specifically, there's research to suggest that something like a loaded heel raise with a toe extended position with a towel underneath the big toe or all of the toes can be a beneficial way to provide some kind of titrated load into the plantar fascia and into the entire lower leg. Also with the understanding that it can provide some short-term symptom relief, and that the changes to the structure of the fascia down the long term over multiple months, if it gets progressively loaded enough with the enough intensity, there can be changes to the tissue of the fascia, but it may not be necessary, or that may not be the main reason for these exercise-based interventions. It's ultimately providing some level of input into the system and providing some short-term symptom relieving effects. And for individuals that do need to rebuild their kind of tolerance and capacity to a variety of lower body demanding tasks or job activities or sports, that is one way to kind of titrate and kind of gradedly expose the fascia and the foot and the whole leg to those type of activities. What are your thoughts, kind of big picture with all of that, Mark?
Yeah, I'll somewhat break this up into short term, long term, but a common question is asking about what somebody can do to make it feel better in the moment. As we discussed, although it's not a primary inflammatory condition, if somebody wants to ice it, rub it, roll their foot on a frozen water bottle, listen, anything that you do that makes your foot feel a little bit better, that's fine, right? If you're massaging it, I wouldn't suggest, digging right into that origin of the plantar fascia that's like causing you extreme pain, especially if it's actually just making your symptoms worse. And also knowing, as Chris said, you're not quote unquote breaking up the plantar fascia. Like that's not something that happens, and that's not something that you would want to do anyway. But listen, if you're doing something that feels good, fine for the short-term relief. It's probably not the long-term solution. Other interventions, yeah. So foot orthoses or inserts or orthotics, it doesn't necessarily matter if they're custom and you're spending a lot of money, or they're off the shelf, or if it's just a gel insert. So you could always start with the cheaper option, the gel insert or the off the shelf foot orthoses. And if you've been at this and you've done all these recommendations for years and you want to try custom orthoses, that's okay too. The outcome as it relates to research isn't really much difference between the two, but those are options there. In terms of shoe wear, there's going to be individuals that say, hey, you have to wear a certain specific shoe for plantar fasciitis, and you can find what's comfortable for you. For the most part, for short-term relief as it relates to these orthoses, shoe wear, we're thinking about changing the distribution of forces to reduce symptoms on that area. Now, we can think about this from a more long-term perspective. So if someone is highly symptomatic and they're currently in a slightly more rigid shoe, based on what we talked about earlier in terms of the things that load the plantar fascia more, weight bearing, extension or dorsiflexion of this big toe, plus load going through the calf Achilles complex, the recommendation probably wouldn't be let's immediately throw them in a minimalist shoe. Because if anything, that minimalist shoe is going to increase the load that's already going through a symptomatic plantar fascia, right? If your goal long-term is, hey, I want to try to increase my capacity and my tolerance to handle load, and eventually you want to transition to a more minimalist shoe to do that, you can do that. But, I wouldn't say there's this blanket statement of you should swap from this shoe to this shoe, because all we're doing is thinking about how is that influencing the load that's going through that structure. What else? Corticosteroid injections. There was a somewhat recent randomized controlled trial. It can provide some short-term relief, but over the course of the year, it doesn't provide any more benefit than just, education and the use of like a foot orthosis. So, and given what we know about the possibility of negative effects of a corticosteroid injection, for other tissues, I would generally steer away from that. And then exercises, I think it's the same rationale as the shoe wear, right? If someone is highly symptomatic, they're that construction worker who's on their feet for 60 hours a week, they're not getting much rest, that's probably not something that you necessarily need or want to throw more load onto, because that additional load might actually be problematic. Whereas if we're talking about the runner, maybe some of that exercise is a supplement to the reduction in the running that they're doing. So they're running 20 miles a week. You pull it back a little bit. You have them do some cycling. You also throw in some heel raises. That's that's fine to do, but we're balancing out this equation of, what they can tolerate and what we're trying to add or remove based on their symptoms and their function. And I think that's true with stretching as well. I've given some recommendations in the YouTube videos with regard to kind of pulling your toes back. And this is based on a couple of studies in 2003, 2006, I believe, from Di Giovanni. And they found that provided some relief for patients. And, there's some comments on YouTube that said, well, I followed a different video that said I should, curl my toes the other way. And I'm okay with either one. Maybe curling the toes the other way helps them reduce some strain that's going through the plantar fascia. It's okay to experiment a bit here. As I stated earlier, it can be helpful to determine what is your baseline, right? What's the number of steps you're doing? What are the activities you're doing in the gym, on the court, on the field, or at work? And then shuffling your life, your exercises, your activities slowly based around that. And the nice thing about something like the foot orthoses is that usually they're relatively cheap and you can trial it. If it doesn't work, you remove it. Taping is the same thing, right? You can follow a YouTube video and tape it. And that can be an even cheaper thing to do, but then you have to learn how to tape and you have to reapply it. Whereas the gel insert or the foot orthoses is quicker and doesn't require any skill or knowledge of a certain technique. I think I covered most things without being kind of broad, but
Last one, what are your thoughts on night splints?
I don't really see the value in it.
Let's go into a case study before we round things out. And this case study is about myself. So, Marc, maybe I give you just a background on when these symptoms started and where we are today. And then if you want to dive further into any more questions, we can with where I'm at.
Go for it.
Two-ish years ago, maybe a little bit longer, I had that typical wake up, feet on the floor, start walking, heel pain. I can't remember which heel it was or if it was both heels, but it started at some point, maybe a year into clinical practice. And from there, the past 2.5 years, it's fluctuated, but there hasn't been a really prolonged period of time where I haven't noticed the symptoms. And more recently, within the past, I would say 3-ish months, 3 to 6 months, the symptoms are right now bilateral. They're pretty intense to where I feel like I'm kind of limping first thing in the morning. I notice them more throughout the day. And it's obvious that they're not improving in it. And I'm having more of these proximal, kind of spread out, diffuse symptoms outside of the local kind of calcaneal plantar heel insertional symptoms. Have I adjusted anything yet? Within the past few days, I've made a few adjustments and we can dive into it. But before then, because the symptoms for the most part, stereotypically, like a lot of people experience, they did warm up with just more walking and as I went throughout my day. And I was able to tolerate the training that I was doing. I haven't adjusted any of my training or any of my day-to-day because the symptoms have become so what feels like limiting and uncomfortable the past few months. I've now considered making adjustments. Should I have made those adjustments much earlier? Probably. And I was very stubborn. So this is where we currently are. Marc, do you want me to outline kind of what my typical week looks like, or do you have any initial questions?
I don't have I know more about your back. Like, do you want to speak more on your history as it relates to GI and
Sure.
other bodily symptoms?
Yeah, I am also not convinced that this is just an isolated episode of plantar heel pain. I'm concerned or would be interested in going down the path of determining if there is a systemic component. So I've had these bilateral symptoms for quite a while at this point. I've also, since grad school, since about COVID time, 2020, I've had bilateral medial elbow tendon pain. That was onset by doing way too many pull-ups during COVID when I was at the house in between classes, and it is not fully resolved since. And I've had these other systemic things. My mom has Raynaud's, but I definitely have finger and toe just cooling, super cold, morning symptoms when I wake up. And then I've had irritable bowel symptoms throughout the course of my life. Got a colonoscopy when I was 21. They were like, it's irritable bowel syndrome. And so it's been all these cluster of things. And more recently with these kind of bilateral elbow symptoms, the bilateral plantar heel pain. I've also had fluctuating left and right bilateral patellofemoral pain. Is there something more systemic that could be causing or be an answer for these symptoms? And I haven't seen a rheumatologist, and I haven't gone and investigated further. But I'm wanting to go down that path now because it seems like more and more things are popping up as I get older.
My thought process is, I didn't know you. You're a patient that I'm seeing for the first time. You report to me that you have a history of, and you're coming to me for plantar fasciitis, and you report to me that you have had symptoms for 2 years. It's now bilateral. It's not improving. If anything, it's worsening. It's becoming a little bit more diffuse in nature. And then you say, well, I also have elbow symptoms, patellofemoral pain. I have irritable bowel syndrome. This is not something that requires emergency room, right? And this also isn't something that only requires management from a medical doctor. What I would say is, because based on what you're saying, you haven't really done much for it. You are pretty rigid with your approach, and that can get some people in trouble. Like, I'm not good at anything in the gym, but I'm also very, I'm not rigid with what I do. So if I start to feel these little things pop up, I just change my routine, but what I would say is there's things that we can work on together in physical therapy, in rehab. Let's work on those things. But also, given the fact that it's bilateral and it's been 2 years and you have knee pain, elbow pain, irritable bowel syndrome, and maybe some other things going on, let me refer you to this great rheumatologist that I know. And now I'm working together with another healthcare provider to get you the best outcomes possible, because it could be just a localized issue and these things are coincidental, but if not, I'm not helping you with the best possible plan of care. So I would say, great, this is what we're going to do together, but this is also something that you need to do with the help of another healthcare provider, given that information.
Yeah. And I told you last week or a few days ago of what my training has looked like and how I haven't changed really any training, but as of this week, I'm starting to make adjustments. But a typical week for me, and I'm a creature of habit, so it's pretty much looked the same for the past year plus. I'll run 2 days a week, and pretty much for the past year, it's been running 4 miles each time on the treadmill. My mileage stays the same. My speed stays the exact same. I'm running like a 9:30. I haven't really changed that. And then 4 days a week, I do some type of resistance training. 2 days a week, I'll do lower body with some kind of low volume plyos, some compound lifts, and then some accessories twice a week, and then upper body, the same thing. And for the most part, the running 2 days a week for 4 miles, the resistance training, the plyos, it's been manageable. I train first thing in the morning. So it's been, all right, the feet are achy, the heels hurt. As I warm up, it's tolerable and I can get through a session and I don't have major kickback later in the day. But as the past month or two, it's become, this doesn't feel great for more and more of the session, especially with the running. So my change within the past essentially session of running is, all right, maybe I should stop running 4 miles twice a week. And what I've done, and I'm curious to hear your thoughts, Mark, but I've also been, again, stubborn and not wanting to remove all running. So my initial plan is I'm going to run 1 mile twice a week. And during the rest of the time that I would be running, I'm going to go on the stationary upright bike and see how that is as a starting point. And if it's not obvious that that's moving things in the right direction, then maybe I remove that 1 mile twice a week and just take off of running for a period of time to let things calm down even more. In addition to that, I did buy within this past week some cheap Amazon kind of orthotics for my work shoes, and I put them in a few days ago. And it seemed to have made the day of work in the clinic more tolerable, but I feel like I just need a few weeks to figure out if it's consistently improving symptoms, but it definitely hasn't worsened them. So those are the two changes I've made so far. And I do plan to reach out and develop an initial consult with a rheumatologist for kind of further investigation of the more systemic things. What are your thoughts with those initial tweaks?
Yeah. So first of all, you're not my patient, right? So I would ask, if we hadn't already discussed this a little bit, Chris, is this something that bothers you enough that you want to try to address it?
Yes. And I was actually talking to my girlfriend about this a few days ago. One of the things that I've noticed more recently is like certain days out of the week after work when we have time, we'll go play pickleball. And more recently, I've had such uncomfortable symptoms that I've stopped wanting to go and do that type of activity. And that's been kind of the biggest change for me, that hesitancy to engage in something fun. That's definitely now made it more of a driver to want to make these symptoms more manageable, to not have to limit myself long-term for those activities.
Okay. So now, as you not being my patient, I've established that you are ready for some kind of change in your life. Now, what I would probably try to get at, understand, is why have you had this stubbornness with running, right? So I wouldn't present it like that to a patient necessarily, but I would ask you, Chris, you run 4 miles twice per week. What's your goal with running? Why do you run?
Yeah, about a year and a half ago, I had this urge to just develop the ability to feel comfortable running. I was consistent with other forms of cardiovascular exercise, incline treadmill walking, Stairmaster, different type of aerobic circuits, but I wanted to just build up my ability to like go out and run. And so I started, shout out Alec Blennis, I started a hybrid resistance training and really early beginner running plan that was pretty conservative in nature. And I finished that plan over the course of like 6 months. And I was able to easily tolerate 3 to 4 miles of running a few days a week. And I've had this sense of kind of accomplishment of this is now quite easy cardiovascularly, and I can sustain it. And it doesn't, really impact my resistance training. I think it's that I've built it up to where now I'm kind of concerned that I'll lose it. And I enjoy now running besides now my feet hurting.
I understand. At this time, it sounds like you've swapped the 4 miles twice per week to a single mile. So are you comfortable with cross training, given your symptoms? Like, are you comfortable exchanging that running volume to something that is more tolerable or completely asymptomatic, such as riding a stationary bike?
Yeah, I'm comfortable with it, like begrudgingly. Yes, I am comfortable with that.
How do you feel knowing that potentially by doing this, maybe you'll even improve your cardiorespiratory fitness because you're not limited by patellofemoral pain or plantar heel pain, and maybe with the rest of the plan that we come up with, you're able to build back a little bit better, a little bit stronger, And maybe when you eventually resume running, if that is a goal of yours to resume running 4 miles twice per week, what if I said, hey, there's a possibility by doing all of these things and not just continuing to push into the pain, that there's a possibility that you could actually come back a faster runner or a longer distance runner and have the ability to do a very meaningful activity to you, which is playing pickleball with your girlfriend a couple times per week.
Sounds nice. Sounds like something I want to do, but it's easier said than done when I've been pushing it off for so long of not making these changes.
Yeah. And so I would tell you, I can't guarantee that you're going to run faster than a 9:30 for 4 miles whenever you get back to running. I can't guarantee that you're going to be a better pickleball, right? I'm not going to say I'm going to make all these guarantees, but I'm going to say you can give yourself a better chance at doing some of those things, probably if you just temporarily, this doesn't have to be a permanent change. This is a temporary, modification to your exercise routine. And so that might also include, modifying some of your plyometrics. Maybe that includes changing up your exercise routine. I recommended to Chris that he try out the cheap off-the-shelf foot orthoses. So go ahead.
Yeah, I have a follow-up question with that. If you were my patient, or if I was your patient, so those 2 lower body days, I'm doing some pretty heavy heel raises, one on a leg press, single leg, sets of like 8 to 10, and then one standing deficit with a dumbbell. They're not irritable in the moment. It's obviously loading the plantar fascia. Do you think that's something that's worthwhile to keep in during those 2 lower body sessions? Or do you think that's also potentially something that should be temporarily modified?
You got to be careful with changing too much at once. So if you stop pickleball, you stop running, or you run less, you do less plyometrics, and you're changing a lot of variables, and then it becomes harder to know which of those variables are helping. But it also could lead to unnecessary deconditioning. Like maybe it doesn't matter in the long term, but now you pull out all of these things that are loading the plantar fascia. Yeah, I'd have to look at your program more specifically, right? Like how many sets are you doing? What other exercises are you doing? But I'd be mindful of changing too many variables at once before determining, maybe what are the most important levers for you to pull.
Totally. Well, I'm hopeful because I haven't made any change in 2 years. That these small but large changes of modifying or minimizing running and kind of continuing with these just cheap Amazon orthotics for during the clinic day and week, that shows over the next few weeks and hopefully months that the morning symptoms, I'm in the clinic, I'm sitting for a long period, I get up after an hour or two of an eval, that the intensity of those starts to drop down slowly over time. Anything else for my case that you think is worth kind of bringing up for the audience?
No, but I did forget to mention health-related changes, lifestyle-related changes, just for the general management. And as I've said before, this is very easy for me to say in a general, broad perspective on a podcast. It's much harder to do face-to-face with an individual. But if there are individuals listening and they say, hey, you did say that there is an association between higher BMI and plantar fasciitis, and that sounds like it relates to me. Should I lose weight? And, my recommendation, like my broad recommendation generally in these videos is, hey, if you've been meaning to make a change to your overall health, that can play a role in your recovery. I don't think rehab should be driven by guilt or shame or things like that. But if that is an option for you, an opportunity for you, and you want to try to eat healthier and walk more alongside these other recommendations, there's never going to be necessarily a harm in that even if it doesn't necessarily influence your localized symptoms, being healthier is being healthier. But I wanted to bring that up too. Like I put it in YouTube videos. I say it in podcasts. Once again, it's very easy to say to an audience of thousands of people, that's not always a lever that you pull with the person sitting in front of you. Like, yeah, it's challenging. Yeah, it's very challenging.
For sure. Well, I'm glad we could talk about myself with this case study, and hopefully we can give an update in future months. I'm crushing it. I'm back, or at least I'm better than where I am now. So we'll have to give the audience an update at some point. And if I end up having some weird rheumatological thing, I feel comfortable bringing that up. So we'll figure that out down the road at some point as well. All right. For people that want for more information on this topic, again, the newsletter will have this resource guide on plantar heel pain, plantar fasciitis. It has linked papers, recommended reading. It has previous podcast episodes, YouTube videos, articles, etc. So we'll link where to get the newsletter and where to get the resource guide in the show notes. Mark, we'll call it there. Thanks again.